this is a very dry topic because you have to go back to the basic. Okay. So if you go to the history, X-rays is actually was accidentally discovered. This scientist, he was actually studying about electricity conduction, where he noticed that a fluorescent screen very near to him start to glow every time he conduct his study. The fluorescent screen glows, so he knew something is going on with his study, but at that time he still cannot. He did not know what's happening, so he named the rays as X-rays. Okay. After a few years, he studied further on the matter, and that's how he got his Nobel Prize in physics. So this is the first radiograph taken of his wife. So you can see the ring is still on the finger. Technically, now this is a wrong technique lah. Okay, when you perform X-ray, you have to remove everything. Okay, so X-ray is actually parts of electromagnetic energy. How it behaves is like the light rays, but difference in wavelength make it having a slightly different quality. So it is more penetrative. That means light rays you can stop by just a piece of paper, but for X-rays it must be blocked by very dense material. And important thing about X-rays, it is ionizing radiation. Okay. So ionizing radiation means energy that can actually remove electrons from a stable atom. Okay. Few imaging modalities that's using ionizing radiations are radiograph, CT scan, mammography, fluoroscopy, angiography, and also nuclear medicine studies. So whenever you are involved or you go into these rooms where this examination is performed, you have to be very careful. You have to put extra precautions that you will later on learn in another lecture. Okay. So any type of electromagnetic wave that can remove electron from an atom, we call it ionizing radiation. So what happened? What possible thing that can happen with ionizing radiation? So number one, it can pass through human without any damage. Number two, it may damage the cell, but the cell repairs the damage itself. And the
Doctor?
radiation, yes?
Sorry, doctor, there are students who want to join. They are waiting.
Okay. Let me see. Okay, so now we have 44, yeah? Okay. Okay, I hope all join early. Okay.
Doctor,
yes?
I'm not sure how, but before the lecturer
Yes.
the host can choose someone to be co-host.
Okay.
So that if someone got lefted after this because connection or someone can approve.
Okay.
Instead of you.
Allow. I do not have that function. I don't know where is the function.
Oh, okay. I also don't know. It's okay.
Okay, so you all just alert me whenever your friend is having any problem. Okay.
Alright, doctor.
Okay. Okay. So another harmful effect of radiation is actually it causes cell dies. Okay. So main source of radiation, actually there are lots of source of radiation, but the most important that we want to focus on is man-made X-rays. Okay, the process of X-ray production is actually a very inefficient because you use lots of energy, but the X-ray produced is actually very small. Okay, so this is the X-ray tubes, how the X-ray is being produced in a simple way. Okay, so I think in a simple way how to explain to you, they use electric, okay, the energy of electricity. So they heat the anode and cathode. From this heat, some electrons are being produced. The electrons will move because of the different positive and negative wave. So it will move and hit the metal target. So this is where the X-rays is produced. So as I said, production of X-rays is very, very inefficient. So only 1% of the energy from the electricity used is going to be converted to X-rays. And then this X-ray we still have to filter. We only want the useful X-rays to hit the patient. So the one with a very low energy, which is not beneficial, will be further filtered so that even less X-rays is being produced. So actually production of X-rays is very, very complicated and inefficient. So that's why one of the things that you always hear in radiology department is machine is being down because of terbakar, okay, because of the heat actually. So management of heat in all radiological equipment is very, very important. Okay, so what happened with the X-rays? So what we want is actually the X-ray with enough energy to pass through the patient and hit the imaging plate. So this is the X-rays that we want. Okay, but some of the X-rays, it will go into the patient and stop there. This is what we call absorption of the X-rays in the matter. Okay, so with this there are change of reaction, whether this X-ray is causing cells death or cells injury or not. Okay, and the other type of X-rays, it will go into the patient, but it is going to be the energy is partially absorbed, so that the X-ray itself is actually deviated. So it passes through the patient, but it's not hitting the imaging plate. So this will hit you lah, the observer, the operator, the staff, okay, inside the imaging room. So this is what we want to, this is unnecessary X-rays. We don't want this type of X-rays, okay? So that's why as students, later on when you are in the room observing any procedures, you should protect yourself because there will be lots of scatter inside the room. The X-rays which hit the patient but never goes to the imaging plate but hitting somewhere else, okay? Okay, so how much X-rays can penetrate a person? So it depends on the tissue depth and also atomic weight. Okay, for example, we have the same tissue, soft tissue. So you imagine the gluteus muscle. So gluteus muscle is very thick, okay, compared to your back muscle, which is very thin. So same amount of X-rays, going through a thick muscle, only one will pass through. But going through a thin muscle, all can pass through. So when X-rays hit the films, it causes blackening of the film. So you see those going through lungs. So you see lungs being black. But those seen through, for example, bones will be white. So that's explain the difference in atomic weight. So atomic weight of tissue also determine how much X-rays can penetrate. For example, lung tissue is very thick. If you compare to scapula, for example, very thin. But then less X-rays can pass through, so that your scapula is white, your lung tissue is black. Okay, and then to reduce exposure to the patient, scientists have done lots of things. One of the things is how image is produced. So actually, a small amount of X-rays, okay, will be targeted to the X-ray films. So in the X-ray films, at the back and at the front, there will be fluorescence coating. This fluorescence coating is actually will enhance the energy of the X-rays. So that means, for example, you give only one X-rays, but the fluorescence will make it glow as if you gave patient 5 X-rays. So good imaging can be produced with little amount of X-rays. And then X-rays have different effect on different tissues. Okay, so for example, for fluorescence screen just now, it'll make the fluorescence glows. Okay, for film in radiography, it will makes the films, if the X-ray hit the film, it will blacken the film. Okay, for living cells, it can cause cell damage. Okay, so cell damage, the use is why it is radiotherapy is used. It can kill the cancer cells, but at the same time, it also can turn normal cells into cancer. So that's why we must use X-rays very selectively. So this is what I told you before. X-rays, more X-rays through the lungs will cause blackening. Less X-rays through the bones is cause whitening. So this is the principle of radiographic density. So you see on a plain radiograph, you see a different grayscale of white and black. Okay, so you see the metal as being very, very white. Okay, bone is also white, but tissue is intermediate and air is lucent or black. So that's how you get underexposure or overexposure in your radiography. So you learn or you listen when you do what rounds, the doctors start to say, oh, this is underexposed film, this is overexposed films, okay? So depending on amount of the X-rays exposure. Difference, okay, computed radiography. So nowadays, most of the hospital is using computed radiography. For example, our hospital, UMMC, all the X-rays done is using computed radiography. What's the difference? It is similar as your camera last time. Okay, so camera last time you have to use film to and you have to develop the film to get the image. Nowadays, cameras, usually the images will be stored on a imaging plate, so you don't have to go and develop the films anymore. So now they use a computer to read and digitize the image. Okay, so that's the only difference. So fluoroscopy. Fluoroscopy is actually another examination using X-rays, but this time instead of having the image on the imaging plate, now we use X-ray source and fluorescence screen and review the image real time on TV like monitor. Okay, so if you look at how fluoroscopy is developed, okay, so you see previously this is how the examination was performed. So radiologists will be directly, this is the X-ray tube. So the radiologist will be reading the imaging plate directly. Okay, ni macam Tok Bomoh lah ni, tengok dahi nampak disease. Okay, so this one radiologist tengok, okay ni cancer, okay ni intestinal obstruction, okay. So and then they thought this is it lah, ni macam magic punya development in medical. Tapi ni semua before they found out the effect of the radiation. So at that time, many of the radiologists developed early cataract, early radiation dermatitis, okay? So that's how they start to know about radiation effect. So nowadays, if you look at the fluoroscopy machine, There are lots of improvement. Okay, so nowadays radiologists just look at the image on the monitor. No need to look directly. Okay, and then even in the fluoroscopy room itself, you see lots of protection device. Radiologists have to wear the gown, and there is also the shield. Okay, in between radiologists and patients, and you look at the gloves also, like glove, thyroid shield, and for long procedures they even have goggle. Okay, common procedures using fluoroscopy, for example, barium swallow, barium meal, and then for orthopedic, they use a lot in II for fracture reduction, to put all this K-wire and everything. So that's part of fluoroscopy procedures. Angiogram, cerebral, heart, and also peripheral limbs angiogram. They do use X-rays for PICC placement, and many urological procedures are also using fluoroscopy, and also pain management, for example, to do discography. Okay, so these are some of the images that you see, different images using fluoroscopy. So for you, you have to know whenever you are shown any of the image, you have to know name of the examination. You have to know roughly how the examination is actually being performed, preparation of patients to have this examination done, contraindications, okay, because that's all what you're going to do later on when you pass and you become houseman or NOs, okay. So angiography, DSA, is also a type of fluoroscopy technique. This one, you have to inject contrast into the vessels. So the principle is actually they took first X-rays, and then they inject contrast and took another image, and then computer will compute the image B minus image A. So whatever image already present before you inject the contrast will be masked or subtracted. So that's how you see only vessels. Okay. So this is the image. This is the non-subtracted one, angiography. This is the subtracted one. So for cerebral angiography, most of the time we want this subtracted type of image, okay, because the vessels are very small. With the overlapping bones, it may mask the findings. But if you look at the orthopedics, for example, lower limb angiogram, usually they want with the bones. They don't want the digital subtraction so much because they want to know the relationship of the vessels. For example, patient with trauma, having fractures and cuts, artery at any side, they want to know where, about how many centimeter from the knee, how many centimeter from the ankle, so that when they want to repair, they can directly go to the side or to the point rather than having to dissect the whole lower limbs, okay? So that's how the difference, okay? So we can produce both of the images, okay? So depending on what the clinician wants, we can produce both, because nowadays it's very simple, just a click of button, you can produce the subtracted or non-subtracted. And the images, you can have the contrast to be white or to be black. Just invert the image on the computer and you can get both. Previously, angiography, you can only get like one, either black or white colored contrast. Okay. CT scan. Okay, CT scan, actually it was invented because one researcher studied about CT scan using money from EMI. At that time, EMI was very rich because of the battles punya famous. Okay, so that's why dulu nama CT scanner ni sebenarnya EMI scanner. Okay, because the patent belongs to EMI. After that, it's become CAT scan because at that time, only axial images can be produced. But nowadays, we just use CT scan because we can produce multi-direction. Okay, so again, it's using the X-ray source, but now they have a lot of detector. So one source, you can produce a lot of a stack of images. Okay, and then this stack of images will be constructed using computer and you can view the image. So radiographic density on CT scan is different. So you can have now with X-rays, you do not have value. With CT scan, you can have value. So each of the anatomical parts, you can have a value. So how does it helpful? For example, in this case, you see the patients have cheek swelling, okay, and then hypodensity within. So now we don't know whether this hypodensity is air, such in abscess, or is it parts of his fat. So we can actually measure air here is negative about 700. So when we measure here, it's actually negative 56. So it's equal to fat region here. So this is not air. So this is not air forming abscess. Okay, so that's how we use HU unit on CT scan. Okay, so and then nowadays we can produce multi-planar reconstruction. You can produce in any direction that you want. Okay. So mammography is also another one examination using low dose X-rays. Okay. So I'm showing you the conventional mammography. So this is old mammography system many years ago in breast center. Now in IMC we have a very new, it's even clearer than this. So the revolution of the imaging is also making mammography better and better. Okay. Nuclear scan. Nuclear scan is using gamma radiation, not X-rays. Okay, so the gamma is actually, hello, yes?
Sorry, Prof. There's one student more waiting to join.
Okay. Okay. Okay, so gamma scan, you inject the patient with the tracer, and then the tracer will go to a specific areas and start to emit radiation. So this is a very low dose, and you use the gamma camera to capture the image. Okay, so this one, I think nuclear scan, Dr. Xray will talk more on another session. Okay, so nuclear scan, you can do also lots of studies. And then nuclear scan, if you see anatomically, it's not very clear, but we focus more on the functional. Okay, so more of the functional of the, so it can complement the rest of the examination. So PET scan is actually fusion of CT scan and also the gamma images. So if you look here, when we do a CT scan, we see a few changes in the bones, but from CT scan alone, sometimes very difficult to differentiate which one is actually degenerative changes, which one is metastasis, because CT scan is only anatomical illustration of the disease. Okay, so when you fuse with the gamma images, which is functional, so you see here the sclerotic changes here is actually not metastasis, so it doesn't take up the contrast. Okay, but for here, it actually, this is the site of metastasis, and another one here. Okay, this is where, so this is how you use the PET scan. So I think that's all for today's session. If you want full lecture notes, you can actually go to, I put the lecture notes into my website. But it's not yet complete because this is the first time I put the lecture notes on the website. I will update the lecture notes from time to time. But I'll share with you how to review this website. Okay. Hello. Okay, let's see. Can you see my screen now? Hello, can you see my screen now? Okay.
Yes, doctor.
Yes, doctor.
Okay. Okay, you just type in HTTP. So, radiologycases.my. Okay. So, you'll go to something like this. So, actually, I've put lots of cases. If you want to go through, it's okay. But you just go, for today's lecture, you just go to notes. Okay. If you see quiz here, this is actually for MX. So I plan to put later on for undergrad, but I let you all know lah. For the time being, all this quiz here is actually for master students. Okay. So for today's lecture, just go to your notes here. Is it clear?
Yeah, doctor.
Any question?
Doctor, Prof, I have a question. I came across with a word collimation, but I didn't understand about the collimation thing.
Okay.
In fluoroscopy. Yes,
Okay.
collimation in fluoroscopy. Can you explain a bit more about that?
Collimation is actually used in all X-ray procedures. Okay, we have whenever we want to do X-rays, we want only to expose patients to the certain parts only. We do not want to expose everything, right? Okay, so when we say collimate, I'll show you again the. Let me see whether I can. Okay, so when this is the X-ray tubing, you can see, right, the image now. I'm showing you the image. Okay, so there'll be a small opening. Okay, so there'll be small opening, and then from this opening, the radiographers actually can mark the region where the exposure is to be made. Okay, so that's what we say collimate. For example, abdominal radiograph compared to your KUB radiograph. So you will see that the abdominal radiograph, there will be side crop. So not the whole abdomen will be exposed to the X-rays. There will be side crop. So it will not include the fat lateral. They will just include the area where the kidney, ureter, and bladder should be. Okay, so same thing when you do ankle, you don't want to expose the whole tibia fibula inside the image. So the radiographers can actually put a border where the X-rays should hit. So that's what we call collimation. Clear? Is it clear?
Thank you, Prof.
Okay, any other question? Any other question? No? Then can I stop the class? Okay, so thank you. Anything you can always email me later on. Okay. Thank you everybody for joining. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullah. Thank you, Rasa.
Thank you, Prof.
Thank you, Prof.
Okay.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof. Thank you, Prof.